Assalamu alaikum wa rahmatullahi wa barakatuh. You're listening to ReviveFM Podcast. This is a family medicine podcast where we review pertinent articles, reform our understanding of medical education, and aim to revolutionize the practice of family medicine with our voices. Welcome to ReviveFM. This is your host, Jawaher السعدون. With each episode, we will have 3 respected guests joining us, 1 family medicine physician and 2 family medicine residents. يحييكم الله جميعاً, dear guests. Welcome to the studio. We're happy to have you with us. تعرفون بنفسكم دكتورة منيرة نبدأ؟
شكراً دكتورة جواهر. يعطيكم العافية. معكم دكتورة منيرة الشاوي, Consultant Family Medicine في مستشفى الملك فهد الجامعي بالخبر, جامعة الإمام عبد الرحمن بن فيصل.
الله يحييكي دكتورة جواهر.
شكراً جواهر for this amazing introduction. I'm Jawaher AlZaid, Family Resident in Imam عبد الرحمن University.
الله يحييك دكتورة نورة.
هلا وسهلا ومرحبا بالجميع. أعرفكم بنفسي, معكم نورة AlKaltham. أنا طبيبة مقيمة في طب الأسرة في جامعة الإمام عبد الرحمن بن فيصل.
حياكم الله. Today's episode will be on approach to shoulder pain in a primary care clinic, one of the commonest complaints presenting to our clinics. So we're looking forward for this episode and the floor is yours, دكتورة منيرة.
شكراً دكتورة جواهر, يعطيك العافية. Today our episode, inshallah, we are hoping it will be informative, that will leave you with a better understanding of the most common shoulder pathologies presenting in the primary healthcare setting. In general, musculoskeletal complaints are common, and they present about 30% of our office visit. Although we see that huge number, do we consider ourselves confident in musculoskeletal complaint and shoulder pain to be exact?
إن شاء الله بعد الأبسود هذه we will be.
إن شاء الله بإذن الله. طيب, today we are lucky to have a discussion with our amazing resident, دكتورة جواهر and دكتورة نورة, about shoulder pathologies.
يعطيك العافية دكتورة.
Thank you, Dr. Munira. We are the ones who are lucky, and we will do our best to simplify the approach to the most common shoulder pain differentials.
Inshallah. I'm confident that you will. To start with, Noura, can you please tell us briefly what a shoulder joint is?
Yes, of course. أتفق معك دكتورة. قبل أن نتكلم عن pathologies للشولدر pain, we should be familiar with the joint itself. So لما نتكلم عن الشولدر, basically a shoulder joint is composed of bony structures and a surrounding soft tissue with a special complex of muscles that give that wide range of motion of the shoulder. And these muscles are known as rotator cuff muscles.
Okay.
جميل. وزي ما احنا عارفين, famous rotator cuff muscles are supraspinatus, infraspinatus, teres minor, and the subscapularis. With the bony structure of the shoulder, I believe we are thinking, as we all know, the humerus, the glenoid, scapula, the acromion, and the clavicles.
ممتاز, ممتاز. طيب, from your clinical experience, what was the most common cause of shoulder pain that you faced in your clinic?
Well, مستحيل يمر أسبوع صراحة من دون ما أشوف shoulder pain. And for me, if it wasn't for trauma, it would be arthritis.
I believe that I have seen rotator cuff pathologies the most. Actually, it's most common cause of shoulder pain.
Yeah, I agree with you, Jawaher. Mostly what we are trying to do in our approach is to rule out these pathologies, which are most commonly rotator cuff tear. تقريبا around 45% of the complaint is from the rotator tear, cervical spine problem, shoulder arthritis, frozen shoulder, and biceps problem. طيب, whenever you are approaching shoulder pain, you have to be systematic. طيب, as any complaint. History, physical examination, and investigation if needed, like imaging. Okay?
جميل.
حلو. طيب دكتورة, what's the important point to focus on في الhistory?
طيب, أي case تجيكم shoulder pain, I want you to remember 3 important questions.
Okay.
Ask your patient. طيب, was there an acute injury? Are you losing your strength? Are you losing your range of motion? Okay?
Okay.
Then we'll proceed with physical examination. Can you tell us about it?
Yes, of course, doctor. Examination بشكل عام في any joint حاجة مفصلية للأمانة. So mostly we tend to use the look and feel and move, and it should be bilaterally. You should examine the right as well as the left and try to start with the normal joint. لكن بس عشان ما ننسى أي جزء, mostly in physical examination we start with inspection. In inspection we're looking for atrophy, for asymmetry. we're looking for infraspinatus atrophy that increases the likelihood of rotator cuff disease. Moving forward, we will start with palpation. We look for any tenderness. لا تنسون أبداً أنكم يتشك الكلافيكل AC joint. راح يكون في tenderness حتى على الترابيزيوس والنك إذا كان في عندنا muscle strain. Biceps pathology can present tenderness of the front of the shoulder. لو كان في الباك mostly راح يكون مع الارثرايتس. If it's on the lateral side, you will think of rotator.
Perfect, Norah, perfect. Don't forget that sometimes an overlap might be seen, so keep your suspicions high and consider all of your differential.
I agree with you, doctor. بس عشان أكمل النقطة بعد ال palpation إحنا we will move to the range of motion. So mostly we start with the active before the passive. And if there was no problem with the active range of motion, then mostly there would be no arthritis, no cuff tear or frozen shoulder. But if there is a difficulty with the active, you will check the passive. If the passive is okay, then think mostly of rotator cuff. If there is an issue with the passive, think of shoulder osteoarthritis or frozen shoulder pathology.
That's why we always, others advise us to begin with the active before the passive to save time in the clinic if it's not needed.
بالضبط دكتورة الجوهرة. And if you are in doubt, is it a shoulder osteoarthritis or a frozen shoulder, an X-ray might help in that.
ممتاز. What is the finding in X-ray of a frozen shoulder?
So in frozen shoulder, it would be normal.
Excellent. طيب. What we'll do next in physical examination, دكتورة جواهر?
طبعاً we will go to look for the strength. Then we will move to the special test. As we all know that we have like more than 70 special tests. So we will try to focus to the main important test.
حلو.
عندنا ال painful arc test غالباً راح يكون positive لما يكون patient illicit pain مع الarm abduction على age of 60 إلى 120 degree. برضو عندنا الدروب arm test.
معلش تسمحي لي دكتورة قبل ما نروح next test. If there is a pain, okay, in painful arc test, the positive likelihood ratio is 3.7 for rotator cuff disease. And if not painful, the negative likelihood ratio is 0.36 for rotator cuff disease.
جميل. عندنا برضو الدروب arm test. غالبا راح يبين لنا if there is any pathology في supraspinatus. The patient will be asked to lower the arm slowly from abduction. راح يكون عندنا positive لما يصير عندنا immediate drop of the arm with the pain.
Okay, and the positive likelihood ratio again is 3.3 and negative likelihood ratio is 0.82.
Okay, so Dr. Munira, هذا helps us to rule in or rule out the pathology, I guess.
يعني تقريبا يعني مو نفس specificity we can rule in or out.
Okay.
لكن the positive test is increase the likelihood of the disease.
Okay.
جميل. عندنا برضو lift off test. غالبا يركز لنا على subscapularis. Hand of the affected arm is lifted off of the back of the examiner and patient is asked to maintain this position. It will be positive if patient is unable to maintain this position.
Okay, it's an excellent, easy test. You can look for it if it's not clear. It's internal rotation lag test. طيب. The positive likelihood ratio of this test is 5.6 and the negative is 0.04 for full thickness rotator cuff tear. طيب ممتاز.
Discussing a special test reminds me of OSCEs. Thank you, Jawaher.
طيب, amazing. Now, what better than an actual cases to test our understanding? These cases are all seen in our center.
Okay.
Let's start with case number 1.
يلا بسم الله.
A 55-year-old man present with a 5-month history of shoulder pain that occurred after taking shower while he washed his hair. He now has difficulty in getting things off high shelves, fixing the lamps, and can't put his belt on. He has pain all the time. He had an MRI that show a partial thickness cuff tear. What is the most likely diagnosis?
يعطيك العافية دكتورة منيرة. أتفق معاك إن أحسن شيء عشان نتأكد بس من our understanding is to see يعني actual cases. In this case, the patient is يعني 55 years. The pain is gradual and chronic, يعني more than 5 months. You can see that there's an issue with the active and the passive. So for this case, I would say mostly it's a frozen shoulder.
Excellent. I agree with you. طيب نرجع نسأل نفسنا الأسئلة اللي سألناها قبل.
صحيح.
ممتاز.
Was there an acute injury?
Yes, but not really.
يعني أيوة قال لي إني مثلا وقت الشاور لما كان يغسل شعره. طيب
Okay.
يعني البيشنت أعطانا سيناريو but this is not an acute
Not
injury
related.
صح؟
Yes.
طيب are you losing the strength?
No, we're not.
Okay. Are you losing range of motion?
Yes, نفس ما قلنا he cannot put his belt also.
ممتاز. So it is a frozen shoulder زي ما قال الدكتورة نورا or adhesive capsulitis.
Yeah.
Key point in the history and physical examination to remember.
Okay.
البيشنت ما كان عنده real trauma صح ولا لا؟
صحيح.
Or trauma doesn't make sense. He has pain all the time. He has limited range of motion in all direction, active and passive. والشيء المهم اللي نتذكره إن frozen shoulder can mimic everything else.
Yes.
صحيح. And also it's the second most common cause of all shoulder pain, mainly in the age of 40 إلى 60.
صحيح.
Mostly unknown causes. It could be associated with diabetes, pre-DM, also hypothyroidism.
ممتاز دكتورة.
صحيح. دكتورة الجواهر يعني جبتي نقطة جدا مهمة. It has been seen that the adhesive capsulitis is related or seen in patient with diabetes and hypothyroid. فمتى ما جاك patient يشكو من هذه المشكلة نحاول إن احنا ناخذ له مثلا a fasting blood sugar أو حتى A1C and also to look at their TSH. So imagine that I've recently read a 2016 meta-analysis that found that the patient with diabetes were 5 times more likely than the control group to have adhesive capsulitis.
Interesting.
Yeah. Add to that we have to inquire about any recent immobility due to chronic illness or trauma that might have affected the shoulder and stiffened its capsule.
Excellent. Excellent دكتورة. طيب regarding treatment, if we do nothing for this patient, what will happen?
Mostly it's self-limited. Yeah.
Yes. If we do nothing, they will get better. طيب. Regarding the modality of treatment, either do nothing, physiotherapy, or injection, surgery, all these modality is correct. But لكن إيش راح تسوي? Just accelerate the healing process.
صحيح.
طيب. There is a study published in JCES 2012 studying the long-term outcome of frozen shoulder. They take 100 patients. They did 5-year follow-up with no treatment. And 91% of the patient returned to full or near full function.
Nice.
Okay.
تمام. So to conclude, in case of a frozen shoulder, زي ما قلنا الهيستوري عندنا والphysical examination هو golden tools to diagnose adhesive capsulitis, and mainly it's a clinical diagnosis. But if we are in doubt with other pathological causes, طبعا راح يكون عندنا non-contrast MRI helpful in this situation.
ممتاز دكتورة ممتاز. طيب, moving on to case number 2. A 43-year-old male, 6-month history of shoulder pain, hurt at night, pain with overhead activity, and no weakness. He says he can't lift at the gym as well. What's the most likely diagnosis?
غالباً we would think of impingement, as we also called it rotator cuff tendinitis.
Yes, I agree. طيب, نرجع نسأل نفسنا الأسئلة الثلاثة. Was there an acute injury?
No, not really.
Okay. Are you losing the strength?
Not really, doctor.
Okay. Are you losing range of motion?
لا.
ممتاز. طيب, other differential we can put in mind is rotator tear.
Yes.
Agree?
صحيح.
Okay. So in impingement, how do they present regarding history?
غالباً it's very common in middle age people, يعني من 40 وطالع.
صحيح.
الأونست بين راح يكون عندنا انسيدوس. البين غالباً راح يكون مع الأوفرهيد reaching activity والfrequent repetitive activity above the shoulder.
مثل إيش دكتورة؟
يعني ممكن مثلاً نفس السومر عندنا مثلاً.
صحيح. ممتاز.
البين غالباً راح يكون at night, so the patient will complain that he cannot sleep at this side of the pain. برضو it will be difficulty in some of the activities of daily living.
ممتاز. I agree. طيب, لو البيشنت دكتورة أنت قلتي لو البيشنت ما يقدر ينام على نفس الجهة صحيح؟
صحيح.
Yes.
طيب, لو كان البيشنت الألم في أي position, what do you think of?
غالباً بنفكر بالتير أنه ممكن يكون عندنا rotator cuff tear.
صحيح.
Yes.
ممتاز. Excellent. What about examination finding? مين ممكن تقول لنا؟
Let me go further into that, Dr. Moneerah. As I said earlier, in physical examination, you will start with inspection, palpation, and then you'll look for range of motion. So in patient with in such this case, you would see no weakness. You would see an acromial tenderness. You would see that there is a pain in the aptly scratch test. Also, you would notice that the passive range of motion is normal, it's intact. And also you'd see a normal strength, but pain with testing the mid-arc abduction or the external rotation. If you're doing an impingement testing, either NIRS or Hawking test, also that would elicit pain.
ممتاز. طيب, if you face such a patient in your clinic, how you will treat him?
غالبا راح نبدأ بالآيس, so that it would may decrease the acute swelling and inflammation, and it will provide some analgesia.
صحيح.
Also, we would recommend for the patient some rest, by meaning that avoiding the activity that aggravates the symptoms, خصوصا the overhead activities.
Okay.
Non-steroidal anti-inflammatory drug, it would be a good option for acute injuries. We would give it like for the short course 7 to 10 days.
ممتاز دكتورة, ممتاز.
طبعا ما ننسى الفيزيكال ثيرابي, it would help the patient the most.
طيب, سؤالنا اللي دائما نسأله, when we refer a patient with impingement?
Yes, of course, Dr. Moneerah. طبعا in our primary care settings وفي الكلينيك, we're trying to elevate the patient's pain. So whenever that the patient's symptoms or functions are not improving, especially إن إحنا نعطيهم مدة 3 أشهر تقريبا, we tend to refer them for orthopedic evaluation. And also if we're suspecting another diagnosis, such as rotator cuff tear, labrum tear, or even adhesive capsulitis.
Excellent. You are doing amazing.
شكرا دكتورة.
دكتورة منيرة is like, I'm proud of my residents.
ما شاء الله التيم كله هنا. يعطيكم العافية يا ربي. طيب. So next, case number 3. A 65-year-old male, 3-month history of shoulder pain and weakness after an awkward fall while doing CrossFit. He had pain in the gym prior to this as well. Hasn't been able to return to the gym. He has pain at night and lifting things is difficult. What is the most likely diagnosis?
Well, Dr. Moneerah, this case is different than the others in which we're seeing that there's an actual trauma. So the patient has fallen. I would think of something more significant. So probably a rotator cuff tear.
ممتاز ممتاز. حفظتوا الأسئلة الثلاثة؟
Yes.
أيوة أكيد.
The golden questions.
طيب, was there an acute injury?
أيوة نعم. Yes.
Are you losing strength?
Yes, we are losing strength.
Are you losing range of motion?
No, it's not seen in this case.
Excellent. So, Jawaher, what is the characteristic of patient of rotator cuff tear?
طيب, غالباً it's a common condition over age of 60. It's high as 40% of patient over 60, they will have a tear. It will be, there is a loss of attachment of tendon to the bone, and it could be traumatic or without a trauma.
ممتاز. يعني without trauma إيش سببها ممكن؟
يعني degenerative مع الage.
صح. Excellent. طيب, what finding will be there in examination?
Well, Dr. Moneerah and Dr. Jawaher, mostly and usually in these patients with tear, it might causes for them shoulder pain, shoulder weakness. The weakness often is present with resisted abduction or even external rotation. We recommend surgery if it's an acute one and there is weakness. But if it was of more of a chronic, we start with physiotherapy. But if it's chronic and there is no weakness, then the surgery is not really recommended.
ممتاز. طيب, to understand also, يعني لما يجينا البيشنت في الكومبلين shoulder pain, لما نعرف إيش الفانكشن حقت المصل, we can understand, we can يعني guess what is the cause. صحيح ولا لا؟
I agree with you, Doctor.
طيب, يعني مثلا rotator cuff help to initiate and rotate the arm when it is in the space. Okay? Its job to maintain the stability of the joint and help to raise the arm into the middle level. أي شيء to lower down the arm, this is the job of deltoid. Yeah. High up is the scapulothoracic joint. Anything in between from 60 to 120 degree.
راح نفكر في الروتيتر cuff.
Excellent. This is the job of rotator cuff. Okay. Finally with case 4. A 76-year-old male with 4-year history of worsening pain and weakness with golf activity. He has some pain at night and described the pain as toothache in his shoulder. He noted he has lost some range of motion. What is the most likely diagnosis?
طبعا حاليا أنا أول شيء طرف بالي 3 أسئلة.
ممتاز.
فقاعد أفكر بالنسبة لهذا الكيس واضح عندنا اللوز رينج اوف موشن وهي is older age. فبنفكر في shoulder arthritis.
ممتاز. Was acute injury?
طبعا لا هنا ما في واضح عندنا أي acute injury.
Are you losing strength?
No, we're not.
ممتاز. So I agree it is a shoulder arthritis.
Yeah.
So patient over the age of 55, it's better to always get X-ray before we order MRI.
Sure.
طيب. If we order MRI in this patient عمره 76 وفي weakness و pain, قولوا لي إيش expected finding اللي راح نلقاها في الريبورت.
We might see different things صراحة, different pathology في tendons with the older age.
بنلاقي ممكن نلاقي tendinitis, بنلاقي partial cuff tear, full thickness tear.
I agree with
although
you.
إن البيشنت أصلاً الهيستوري واضحة إنها ماشية مع shoulder arthritis.
فعلا.
صح؟
فعلا.
في هذه الحالة لما نحولهم على الفيزيوثيرابي بنحولهم على إيش؟ هل الفايندينجز اللي في الأمراي شفناها؟
لا غالبا على أساس range of motion يعني.
الهيستوري and physical
صح.
examination.
أحيانا الأمراي it will confuse us. صح؟ إذا الهيستوري clear it's arthritis. Examination X-ray finding is there.
No need
to go further.
I agree.
Okay.
Good point.
طيب. What do you suggest treatment approach with patient with osteoarthritis?
غالبا we concentrate على to decrease the pain of the patient.
Okay.
So first we will start with paracetamol, topical therapies, physical therapy to increase the range of motion.
Okay.
Second line treatment we would go for the non-steroidal anti-inflammatory drugs. If there is no improvement we would go further like for tramadol, duloxetine. If there is no improvement with the pain, we would go like fourth line treatment for opioid, but we have to carefully supervise this medication. We could suggest like corticosteroid injection. It will help like for the short term. If the patient complaining like for moderate to severe pain and there is a clear radiographic evidence of osteoarthritis, we would suggest for joint replacement.
طيب, allow me to ask, when is joint replacement indicated? Like when can we advise the patients for joint replacement surgery?
Excellent, دكتورة. طبعا نعرف إن الأوستيوارثرايتس it's a progressive. وإذا البيشنت كان وهو طبعا يعتمد البين threshold من patient إلى patient. في patient with severe osteoarthritis but he can
tolerate
ما هو على daily painkiller. لكن في patient مثلا moderate osteoarthritis لكن daily painkiller على الماكسيمم دوز. طيب وإحنا نعرف إن هذا this disease is a lifelong. هل راح نترك البيشنت كذا؟
لا طبعا
البنفيت حتى من الفيزيوثيرابي يعني تختلف من شخص لآخر. لكن إذا البيشنت جربنا كل الموداليتيز and he's still in pain, why we are يعني ليش ما نعرض لهم
improving their quality.
صح ولا لا؟
The quality of life.
A good choice, yes.
يعني we can push the patient for joint replacement. It's an excellent procedure. Recovery rate is 80 to 90%. 1 to 2 nights stay. The patient will be on sling for 6 weeks تقريبا. But it's an excellent pain relief. So why not?
Yeah. So we would advise for it يعني eventually if it's needed.
Yeah, if the patient يعني على painkiller for maximum painkiller and daily painkiller, yeah, we can go for joint replacement.
حلو.
Okay, so we can't conclude before we mention a referred pain. صح?
Yes.
What do you think could be a referred pain to the shoulder?
I agree with you, Dr. Muneerah. Now, this is a very important thing to conclude with. So if you're dealing with a joint pain, don't forget that you have to exclude other pathologies. It's not about the shoulder itself. So you can have pain coming from elsewhere, either from neural impingement, and it's mostly at the level of the cervical spine, mostly C5 or C6.
صح.
You should think that you might have it from a peripheral nerve entrapment distal to the spinal column. We might see it in diaphragmatic irritation or even myocardial ischemia. And you should suspect it in a patient with a high cardiovascular risk. Diaphragmatic irritation, you might see it at splenic lacerations, perforated viscus, or even in ruptured ectopic pregnancies.
صح.
ممتاز دكتورة. وهذا دائما يجي ترى سؤال MCQ.
As an MCQ.
طيب يجينا سيناريو pregnant with shoulder pain ولا ممكن ما عملت الالتراساوند. طيب
صحيح.
فالسيناريو يكون ماشي مع rupture ectopic pregnancy.
Good point دكتورة. Now طيب, how to differentiate? Is this a referred pain or an actual pain at the joint? So mostly if it's a referred pain, then the quality would not be differ with the movement, and also in contrast to the intrinsic shoulder problem, the shoulder movement is normal, as I said, and does not alter the characteristic of the pain.
طيب, I have a question here.
Sure.
Does it make a difference? Like, is there different differentials for the left or the right shoulder? As I remember from med school, cholecystitis was cause right shoulder pain.
Yes, of course. Now, mostly it's ipsilateral. The shoulder pain is ipsilateral to the pathology itself. So when you're dealing with cholecystitis, you might see it as a right shoulder pain. But if you're dealing with ischemias, you might see it in left side.
Okay.
Excellent دكتورة. ممتاز.
So I think by this we have came to the end of this episode. It was very beneficial, and personally I have learned a lot from this. But allow me to ask you for a take-home message.
Sure. أكيد دكتورة. شكرا لك. So to conclude, our key message to tell our listener are as follow. In rotator cuff tear, the patient has pain at night, pain with overhead activity, and weakness if there is a big tear. And the pain is, if the tear is small, the patient could have more pain. And if it is a complete tear, sometimes the patient has no pain. And occur most often in older patients and are associated with a positive drop arm sign and weakness with external rotation.
Jamil.
Also allow me to add that shoulder arthritis patient will be present with pain all the time. He will lose range of motion. He will be older age and documented radiograph changes will be shown.
ممتاز دكتور جوهر.
لو بختصر أو حتى أعطي keywords على frozen shoulder, I would say it's a more chronic and a gradual, and most importantly, you would see a loss of range of motion, both active and passive. And to differentiate it with osteoarthritis, try to have an X-ray and check if it's normal or not.
Allah يسعدكم جميعا. This was indeed a very comprehensive overview. I want to thank you one more, Dr. Muneerah, Dr. Jawaher, ودكتورة نورة. نورتونا في الاستديو.
شكرا لك دكتورة جواهر. جوهرة.
جواهر وجوهرة اليوم.
يعطيك العافية. وشكرا دكتور مشاري behind the scene. شكرا لكم my amazing senior resident.
الله
يعطيكم العافية
باختباراتكم إن شاء الله.
الله يسعدك دكتورة ويعطيكم العافية على الفرصة, وأن إن شاء الله راح نشوفكم في الأوقات القادمة بإذن الله.
شكرا جزيلا جميعا. We are so happy. Thank you.
It was a pleasure having you as our guest in this podcast. Don't go just yet, as our refreshing segment is starting soon. Welcome back. This is our refreshing segment. This segment is a fun little break where we will present to you different and interesting material in each episode. Today, I have a special guest to discuss a very interesting topic. So kindly may you introduce yourself, Dr. Mokhtar.
This is Mokhtar AlOmar, consultant clinical pharmacist in internal medicine.
حياك الله دكتور. We're pleased to have you as our guest today. And since we discussed earlier about approach to shoulder pain, in today's refreshing segment, we will touch on approach to pain management. So can you please tell us more about it, Doctor?
So pain management, as you know, it is very broad things to discuss, but we will focus on the medication itself, the pharmacotherapeutic management. So when you talk about medication, as a clinical pharmacist, this is our area. So we'll focus on non-opioid therapy, then we'll go with the opioid therapy, then we'll talk about the different modality of treating pain management. So as a general principle, we start usually with non-opioid therapy with paracetamol as a simple medication, which is acetaminophen in different term. Then we go with the non-steroidal therapy, and we'll talk about the consideration of non-steroidal therapy.
حلو.
Then we move to different modality of treatment, including opioid therapy as the last stage of the management. So pain management, when we have mild pain, we go with non-opioid therapy. When we have a very moderate to severe pain, depend on the cause. Either we have a neuropathic pain or general pain. So we go with non-steroidal, or we can add anticonvulsant or antidepressant therapy in those situations.
Hello. That's a very clear general outline that we can follow in the clinic. How can we choose like the best choice of medication, etc.? Like, let's start with the mild or moderate.
So when we talk about pain management, as I mentioned, with the mild pain management, the common medication for you as a physician, you go with the non-steroidal. You like non-steroidal medications, and that's our nightmare as a pharmacist. So non-steroidal, that cause renal impairments. Some patients who use it inappropriately can cause hypertension, increases blood pressure, and can affect the cardiovascular disease. So we have different consideration. The main things with the GI itself, even.
Okay.
So we care about non-steroidal when using the patients with a GI disease or peptic ulcer, for example. So let's focus on the cardiovascular disease and the GI. So as
the main
a beginning.
side effects for this medication.
So when we have a patient with low cardiovascular risk, then we have a low GI risk. So low cardiovascular and low GI risk, we can go with any one of the non-steroidal.
Okay.
When we have a low cardiovascular risk with moderate GI risk, then we go with non-steroidal with the PPIs, either omeprazole, esomeprazole. We add as GI protective agents. When we have a high-risk GI patient with low risk of cardiovascular disease, we can go with the COX-2 medication, which is celecoxib, parecoxib, any one of the COXib medication, we call it COX-2, with the PPIs.
Okay.
Then the other part is to have a patient with a high cardiovascular risk patients. Then we have low GI risk, moderate, and high. Then our favorite medication is naproxen for patients with a high cardiovascular disease risk. And we can add PPI for those patients if they have a moderate or severe GI risk. And we try to avoid, if the patient have a GI and cardiovascular high GI risk, we try to avoid non-steroidal at all in those patients, and we go with alternative agents.
Which would be?
We can go with opioid therapy. We can go, depend on the situation, depend on the pain itself.
So it depends on escalating.
Yeah, we prefer acetaminophen, paracetamol as we can, but sometimes cannot control pain for the patients.
Okay. And then for the more severe pain, we can give them?
For the more severe pain, we can go, as I mentioned, with anticonvulsant, antidepressant, depend on the situation, affecting the sleep, affecting the patients. If it is a neuropathic pain, we go with the anticonvulsant agent. But let's go back with the different things with the non-steroidal. For the patient with renal impairment, so we need to screen the patient for renal impairment. We need to do creatinine and creatinine clearance for the patient before starting non-steroidal. So we need to keep in mind the patient's cardiovascular history. We need to keep in mind is the patient is elderly, so they are more prone to have cardiovascular disease, hypertension, and even GI disease and renal impairment. So keep in mind in those kind of population, you just screen the patient before starting all these agents, especially non-steroidal, which is an over-the-counter medications.
Okay. And then is there like a max duration of time, like period of time that we can give? Or no?
There is no specific period of time for pain management. Once the pain relief, we stop the medication. We try to taper it down. But there is no specific time to give the medications.
Excellent. And back you were saying, doctor, about the antidepressant and anticonvulsants. When do we advise patients to take them? Like when can we prescribe them and when not?
Yes, that's a tricky question for me. When you add anticonvulsant, yes, if you have a neuropathic pain, or antidepressant if you have a sleep disturbances with the patient, that's the pain is affecting the sleep for the patient, you can add antidepressant sometimes. But which antidepressant, which anticonvulsant, this is the trick where to choose, because there is a lot of side effect with those medication.
Okay.
So let's start with antidepressant, for example. So we have different medications like amitriptyline, which is the very old medication, and you love that medication, but that medication can cause sedation for the patient. That will make the patient sleep, and that's the beauty. You utilize this side effect to make the patients happy and pain relief, and the patient can sleep. But the other things that the patient can weight gain. Can gain weight, excuse me for that. So can have a weight gain and dry mouth, which is one of the side effects. So this is an unfavorable side effect for such patients, especially when it is a lady patient. So you don't want to have weight gain for that.
Okay, clear as that one. طيب, I have another question, if you would allow me, Doctor. What would be the role of opioid therapy in the pain management, and what's the best way to utilize the opioids?
So opioid therapy is the last thing of the management. So when we talk about, we just go back to the anticonvulsant and antidepressant. So anticonvulsant and antidepressant. So we talk about antidepressant, then we go to anticonvulsant before we go with the opioid. So anticonvulsant, you go with the neuropathic pain patients. So you give for patients, for example, have diabetic neuropathy, for example, which is a pain, but because of a neuropathic, it is a neuropathic pain. It's not a general pain. So you go with the pregabalin, gabapentin, these kind of anticonvulsant agents. Sometimes you go with lamotrigine for patients with fibromyalgia, for example. Sometimes they give, or for different indication. For example, patients with migraine, you go with lamotrigine, which is pain because of the headache, because of a migraine. You go with lamotrigine and these anticonvulsant agents. So we go with these agents, and the selection depend on what? Depend on the side effect and patient situations.
Yeah.
So let's say gabapentin and pregabalin. That's a favorable medication for neuropathic pain and will make the patients happy. But if the patient have a renal impairment, you need to be careful with those patients because it accumulates fluids, these agents. When we talk about pregabalin and gabapentin, again, if the patient have a liver disease, you can go with these medication because it is metabolized renally, so we don't worry about them. Okay. And when we go with the carbamazepine, lamotrigine, there is a different side effects. So you need to do a baseline CBC for them. With the lamotrigine, for example, you need to be worried about if you have a dermatological reaction for the patient. So just screen the patient for this side effect later on. Monitor your patients. And these are the main consideration while prescribing these kind of medication.
Nice.
Then the later stage, the opioid therapy. So back to your point, the opioid therapy is the last one to use, and you don't want to use it for every single patient.
Okay.
For example, the common things that use opioid therapy, we know that secular patients, they can use opioid therapy as part of the management. But as we talk about shoulder pain and general pain management, opioid, one of the broad spectrum treatment for any pain. So this is the last option that we use because of a lot of side effects because of addiction. So before starting opioid therapy, you need to screen your patients. You need to assess your patients and score your patient. Is he more probable to have an addiction or not, using different screening tool, which is like, for example, SSI-AP, which is a screening tool for addiction. So you need to ask your patient different questions and to assess that patient if the patient has high risk.
What is it called again, Doctor? SSI?
SISAP.
Okay.
Okay. And you need to do a periodic assessment, a periodic review, which is called 5A, which is assess analgesia, activity, adverse effects, and abuse behaviors, and adequate documentation. So you need to do all these things. So you need to assess your patient. Then even as I mentioned, 5A, you need to assess your patient for abuse behavior. Is the patient addicted to the medication? Is the pain controlled, but he is addicted to the medication? You need to review all the time the opioid therapy because of the side effect. Then the last things you need to document as a physician. You need to protect yourself. Opioid therapy is not a game to play with.
Excellent. There's lots to keep in mind, I'm sure. especially regarding the opioids therapy and when we are switching from an agent to another. I remember there is like an equivalent doses or something. Would you
Yes.
like to touch on that, Doctor?
Yes, you know that opioid therapy, there is a lot of opioid therapy. We have morphine, we have tramadol, we have meperidine, we have oxycodone, we have different agents that can be used. The common one, let's have an example for conversion. So let's say that patient's on IV morphine, which is, for example, 5 milligram IV morphine. So what's the equivalent oral morphine even itself? So oral morphine is the equivalent dose when you give IV 15 milligram is the oral one. So this is the equivalent oral.
5 and
So
15.
let's say that's more. I need to switch from morphine to hydromorphine, for example. Hydromorphine, the oral equivalent to 3.5 milligrams. So 15 milligram oral morphine equivalent to 3.5 oral hydromorphine.
There's some math right there.
Yeah.
Yeah.
So because hydromorphine is more potent, so you need the lower dose on that. So let's say that I have a morphine, which is a common one. We use it IV, which is 5 milligram. Then I want to switch the patient to oxycodone, for example, oral. We give 10 milligrams. So 5 equivalent to 10 milligram oral oxycodone.
Okay.
The last thing that's to talk about is morphine to fentanyl batch, which
Okay.
is a tricky one. So let's say that I have a patient on 10 milligram morphine, which is IV. Then I want to give the patient transdermal batch, which is a patch will be sticked on the patient's skin and give the patient pain relief. So what's the equivalent dose?
I would listen to you.
Yeah. So 10 milligram IV morphine equivalent to a 12 microgram per hour, which is fentanyl batch. So you need to calculate the 24-hour needs, then you can give the strength of transdermal batch. So that's a tricky question. I think we can attach all the tables, that's the equivalent doses that will be beneficial for our physician and junior clinical pharmacist, for example.
Yes, inshallah, we'll make sure to attach it below along with the summary, inshallah, for the episode. يعطيك العافية, Dr. Mokhtar. I am sure there is a lot more to share regarding this topic, but in these few minutes, you have enlightened us a lot. So just allow me to ask you to give us like a take-home message.
يعطيك العافية, thank you for having me again. My take-home message is for you as a physician, just assess your patient very well. Consider your patient as a whole, is not just only for pain. So the patient have a lot of comorbidities, so keep in mind while you're choosing the pain management control therapy, the patient have different comorbidities, GI, cardiovascular, maybe psychiatric issue, maybe sleep disturbances. So consider these kind of comorbidities and these kind of risk factor before prescribing any pain management control. And always consult your clinical pharmacist. So يعني قاعدين نسوق شغلنا as a pharmacist. فconsult us all the time. We are free to respond to your questions.
يعطيك العافية دكتور ويحق لكم. We're very pleased to have you in this episode. حياك الله ونورتنا في الاستديو دكتور. تسلم.
يعطيكم العافية.
If you're interested in reviewing the topics of discussion of this podcast in the link below, you will find the core scientific content that was created by our dear guest residents. If you would like to join us and become a guest of ReviveFM Podcast, you can fill out the application form found in the description box below. This podcast is brought to you by Saudi Society of Family and Community Medicine, as well as Family Medicine Future Group. Continue to follow our podcast on the social media through Saudi Society for Family and Community Medicine and FMF Twitter accounts linked below. Currently, we upload regularly on both Apple Podcasts and YouTube. This has been your host, الجوهرة السعدون. Thank you for tuning in. We hope to hear you next to ReviveFM Podcast. As always, sky is home.